ANCA, associated vasculitis. The discovery of anti-neutrophil cytoplasmic antibodies, ANCA. First described in 1982 by Davis in 8 patients with necrotizing porcine glomerulonephritis 1. Hall and colleagues identified ANCA in 4 patients with systemic vasculitis 2. In 1985, van der Woerd suggested an association between ANCA and Wegener's granulomatosis 3. ANCA subsequently reported in microscopic polyangiitis and in Churg-Strauss syndrome 4. 1. Davis D.J., et al., BMed J 285-606, 1982. 2. Hall J.B., et al., Orstein Z.J. Med 14-277, 1984. 3. Van der Woerd F.J., et al., Lancet 1-425, 1985. 4. Jeanette C.J., Folkar, Newing J. Med 337-1512, 1997. ANCA-associated vasculitis. Shared features of ANCA-associated vasculitis. Wegener's granulomatosis, WG, microscopic polyangiitis, MPA, and Churg-Strauss syndrome, CSS, can be considered together in view of a number of shared pathologic, clinical, and laboratory features. Preferentially involve small vessels, arterioles, capillaries, venules. Similar glomerular lesions, crescents, focal necrosis, porcine. Propensity to present as lung-renal syndromes. Varying prevalence of ANCA positivity. Detection of ANCA. ANCAs were originally described based on their immunofluorescence patterns. Cytoplasmic, C-ANCA, and perinuclear, P-ANCA. The antigens responsible for these patterns have also been identified. Proteinase 3, PR3, for C-ANCA. Myeloperoxidase, MPO, for P-ANCA. Immunofluorescence and antigenic specificity. In C-ANCA reactivity, PR3 is responsible for more than 90% of such reactions. Other antigens may occasionally contribute. Bactericidal permeability inducing protein, BPI. Rarely MPO. In P-ANCA reactivity, MPO is responsible for 10% of such reactivity. Other antigens include elastis, azurocidin, cathepsin G lysozyme, lactoferrin. Anti-nuclear antibodies, ANA, can also have P-ANCA patterns. ANCA testing. International Consensus Statement for Testing and Reporting ANCA recommends. All sera are screened for ANCA by ELISA. If positivity is confirmed by direct ELISAs. Some laboratories test by direct ELISA alone. Others screen with direct ELISA and confirm positive sera by ELISA. A few use capture, sandwich, ELISAs. Problems in ANCA testing. Diversity of anti-neutrophil cytoplasmic antibody target antigens. Assay standardization and performance. Application of anti-neutrophil cytoplasmic antibody testing in a clinical setting with a low pretest probability. The widespread assumption that anti-neutrophil cytoplasmic antibody titers alone may closely reflect disease activity and therefore may be used to guide therapy. ANCA frequencies in vasculitis. Hagenisi, et al., Kidney in 53-3, 743-753, 1998. ANCA in other diseases, connective tissue diseases, infections. SLE, rheumatoid arthritis, myositis. Infections. Endocarditis, HIV. Inflammatory bowel disease. Ulcerative colitis greater than Crohn's disease. Other autoimmune GI diseases. Sclerosing cholangitis, autoimmune hepatitis. Drug-induced ANCA. Hydralazine, propylthiouracil, dipenicillamine and minocycline. Schematic concept of pro-inflammatory effects of ANCA leading to vasculitis. ANCA and disease activity. Pooled analysis studies by Davenport in MJ Nafrol 15-3, 201-207, 1995. 48% of rises followed by relapse. 51% of relapses preceded by a rise. 100 patients followed serially for 2 years by Boomsma, Arthritis Room 43-9, 2025-2033, 2000. 92% of flares associated with rises in ANCA. Predictive value higher with ELISA than with EVE. Greatest utility when tests are negative. Wegener's granulomatosis, history. WG is a granulomatous necrotizing vasculitis characterized by its predilection to affect the upper and lower respiratory tracts and the kidneys. First described in 1931 by Heinz Klinger, a German medical student. In 1936 and 1939, Dr. Friedrich Wegener provided detailed information about 3 patients with a similar illness. Remained relatively unknown in the American literature until the 1950s, when Godman and Scherg published a detailed description of the disorder. WG, epidemiology. WG affects both sexes equally. Occurs in patients of all ages, mean age 41 years, range 9 to 78 years. More commonly seen in Caucasian patients, 97%. Period prevalence of WG, 1986 to 1990, was estimated to approximate 3 per 100,000 persons. It is likely that the prevalence of WG has been underestimated. Only since the early 90s has the existence of mild and more indolent forms of disease has been recognized. WG, clinical features. Classic triad, limited WG, upper airway, lower respiratory tract, kidneys. Limited WG. Relatively mild and indolent without renal involvement. WG, upper airway. Upper airway disease is the most common presenting feature. 70% of patients at onset. Develops in more than 90% of cases. Otologic manifestations. Initial presentation in about 25%. 60% of cases during the course of disease. Serous otitis media is the most common ear problem encountered, 25 to 44%. Nasal disease is a prominent presenting feature of WG in about 1/3 of cases. Eventually develops in 64 to 80%. Wegener's granulomatosis, face. This patient with Wegener's granulomatosis developed a saddle nose deformity with destruction of the dorsal nasal cartilage. Other nasal complications in Wegener's granulomatosis include perforated nasal septum, mucosal ulceration, epistaxis, and boggy nasal turbinates with purulent nasal discharge. Number 1,102,081. WG, upper airway sinusitis, laryngotracheal disease. Initial presentation in about 1/2 to 2/3 of patients with WG. 85% of cases during the entire course of disease. Laryngotracheal disease. Asymptomatic. Subtle hoarseness. Stridor and life-threatening upper airway obstruction. The most characteristic lesion is that of subglottic stenosis, SGS, which occurs in up to 16% of patients. In pediatric and adolescent patients, SGS is dramatically increased, reaching an alarming 48% prevalence. WG, pulmonary manifestations. Pulmonary manifestations occur in 45% of cases at presentation, 87% during the course of disease. Cough, hemoptysis, and pleuritis are the most common pulmonary symptoms. 1/3 with radiographically demonstrable pulmonary lesions may not have lower airway symptoms. The most common radiologic findings include pulmonary infiltrates, 67%. Nodules, 58%. The pulmonary infiltrates in WG may be quite fleeting, appearing and resolving in some cases even before the institution of therapy. WG, pulmonary manifestations. Persistent diffuse interstitial infiltrates are rare, less than 1%, and should suggest other diagnoses. Pulmonary nodules in WG are usually multiple, bilateral, and often cavitate, 50%. CT of the chest may reveal infiltrates and nodules that were undetected by conventional radiographs in 43 to 63% of cases. Less common pulmonary manifestations of WG include pleural effusions, diffuse pulmonary hemorrhage, and mediastinal or hilar lymph node enlargement or mass. Diffuse pulmonary hemorrhage has been reported in up to 8% of cases, and it carries a high fatality rate, 50%. Wegener's granulomatosis, lungs, radiograph. These chest radiographs show large cavitary lesions with air fluid levels from a patient with Wegener's granulomatosis. Number 3,512,031. WG, renal manifestations. Presence or absence of renal disease defines the subsets of generalized and limited WG. Frequency of renal involvement in WG is difficult to ascertain. Limited WG may go undiagnosed in patients with mild disease. By excluding such patients, published series may overestimate the frequency of renal disease in WG. Early renal disease may be clinically silent. Patients who appear to have limited WG at one time may later develop glomerulonephritis. Monitoring of renal status in all patients is important. WG, renal manifestations. Renal disease is estimated to occur in 11 to 18% at presentation, 77 to 85% during the course of disease. Extrarenal manifestations often precede renal disease. Renal disease may progress to fulminant glomerulonephritis within days or weeks, resulting in end-stage renal failure. Untreated, mean survival time for this subset is about 5 months. Initial and recurrent renal damage may lead to chronic renal insufficiency in up to 42% of patients. Dialysis, 11%. Renal transplantation, 5%. Early segmental fibrinoid necrosis and infiltration by neutrophils in an ANCA-positive patient with WG. WG, ocular manifestations. Reported to occur in 28 to 58% of patients with WG and may be part of the initial presentation in 8 to 16% of cases. Any compartment of the eye may be affected. Keratitis, conjunctivitis, scleritis, episcleritis, nasolacrimal duct obstruction, uveitis, retroorbital pseudaedema with proptosis, retinal vessel occlusion, and optic neuritis have all been described. Most ocular findings are nonspecific. Proptosis is a diagnostically helpful finding. Poor prognostic sign for vision. WG, cutaneous manifestations. Reported in 40 to 50% of patients with WG and may be part of the initial presentation in 13 to 25% of cases. The cutaneous manifestations of WG have included ulcers, palpable purpura, subcutaneous nodules, papules, and vesicles. Cutaneous lesions tend to parallel disease activity in other organs. The presence of active skin lesions is a reliable clinical marker for active systemic disease. WG, joint disease. Arthritis is observed in up to 28% of patients. Several patterns can be observed, including monoarticular disease, migratory oligoarthritis, and symmetric or asymmetric polyarthritis of small and large joints. Symmetric polyarthritis of small and large joints may be mistaken for RA. A positive test for rheumatoid factor, RF, may be observed in as many as 50 to 60% of cases. In contrast to RA, the symmetric polyarthritis of WG is generally non-erosive and non-deforming. WG, neurologic. Rarely a presenting feature of WG, may develop during the course of disease in 22 to 50%. Multiple neurologic complications may occur in up to 11% of patients. Peripheral neuropathy is the most common single neurologic manifestation, 10 to 16%. Mononeuritis multiplex, 12 to 15%. Distal and symmetric polyneuropathy, 2%. Cranial neuropathy occurs in 6 to 9%. Cerebrovascular events, 4%. Cerebral or brainstem infarction, subdural hematoma, and subarachnoid hemorrhage. diffuse meningeal and paraventricular white matter disease has been reported. WG, other manifestations. Gastrointestinal, abdominal pain, diarrhea, and bleeding are the most frequently reported symptoms. Relate to the presence of ulcerations in the bowel. Perforation may occur. Genitourinary. Case reports of bladder wall, prostate involvement. Hemorrhagic cystitis, complication of cyclophosphamide. Cardiac. Pericarditis. Myocarditis. Arteritis. WG, diagnosis non-specific abnormalities organ-specific. Leukocytosis, thrombocytosis, high ESR, anemia. Organ-specific. Urinalysis, sediment, creatinine. The sensitivity of PR3 ANCA is about 90% in active WG and 40% when disease is in remission. The specificity of PR3 ANCA in the diagnosis of WG exceeds 95%. In general, the presence of high-titer ANCA by EFA combined with confirmatory antigen-specific assay for either PR3 or MPO in the setting of a high index of suspicion for vasculitis, i.e., high pretest probability, is sufficient for diagnosis, even in the absence of tissue confirmation. Positive predictive value of ANCA: 1. 100. 2. 3. 4. 1. Documented WG. 2. Pulmonary renal syndrome. 3. Systemic necrotizing vasculitis. 4. Rapidly progressive GN. 5. GN. 6. Hospitalized patient. 5. Positive predictive value: 50. 50. 100. 6. Disease prevalence. Jeanette. MOJ kidney dis 18 to 164, 1991. Diagnostic yield of biopsy in WG. Inflammatory lesions in WG. Necrosis. Granulomatous changes. Vasculitis. Diagnostic yield of a biopsy. Nasal, paranasal sinus biopsies. Small amount of tissue available and may make it difficult to identify all of the pathologic features. Complete diagnostic triad is only seen in 3 to 16%. Lung. Transbronchial biopsies are rarely diagnostic, less than 7%. Open lung biopsies reveal various combinations of vasculitis, granulomas, and necrosis in 90%. Kidney. Focal and segmental GN. True vasculitis of medium-sized renal arteries is only occasionally noted, 3 to 15%, and granulomatous changes are equally rare, 3%. The results of kidney biopsies usually not diagnostic of WG. Wegener's granulomatosis, lung, photomicrographs. Left, the pulmonary parenchyma has been entirely obliterated by a granulomatous inflammatory reaction bordering large necrotic areas. The necrotic areas stain darkly because they contain many fragmented pycnotic nuclei. The inflammatory cells in the lighter staining, viable, areas include several multinucleated giant cells. A large blood vessel forms the center of one necrotic focus. Hematoxylin-eosin, low power. Right, a high-power view of an inflamed blood vessel reveals that most of the wall is necrotic and bordered by palisaded histiocytes. The surrounding tissue is intensely infiltrated by lymphocytes, histiocytes, and a few multinucleated giant cells resembling Langerhans cells. With this stain it is impossible to determine whether the vessel is an artery or a vein. Hematoxylin-eosin, high power. Number 9412110. WG, principles of treatment. General. Rapid diagnosis, assessment of extent of disease activity. Untreated, high mortality. Pharmacotherapy. Induction of remission. Prevention of relapse. Management of drug toxicity. WG, induction of remission. Glucocorticoids, GC. Pulse therapy for life-threatening disease. 1 gram Solu-Medrol daily for 3 days. High-dose steroid treatment 1 mg/kg daily. Taper after 1 month. For classic WG, with renal involvement. Begin concurrent daily oral cyclophosphamide, CTX 2 mg/kg/day. Pulse cyclophosphamide has been studied but not currently recommended. Consider methotrexate for less severe or limited disease. WG, NIH Experience Hoffmans, et al., Ann and Turn Med 116-6, 488-498, 1992. 158 patients with WG followed at the NIH for up to 24 years, mean follow-up period of 8 years. 84% received standard therapy with daily CTX and GC. Marked improvement in 91%. Complete remission in 75%. Disease relapse was seen in 50%. Permanent morbidity from disease occurring in 86%. Chronic renal insufficiency, 42%. Hearing loss, 35%. Nasal deformities, 28%. Tracheal stenosis, 13%. Visual loss, 8%. Permanent morbidity as a result of treatment with GC and CTX occurred in 42%. 46% experienced serious infectious episodes. Summary of cyclophosphamide. Cyclophosphamide induces remission, but relapses are common, and cyclophosphamide causes toxicity. WG, efforts to find less toxic alternatives to cyclophosphamide. NIH Open-Label Study, Sneller MC, et al. Arthritis Room 38-5, 608-613, 1995. Open-label study of weekly low-dose EMCs plus GC in 42 patients with biopsy-proven WG. Patients with life-threatening disease excluded. Serum creatinine above 2.5 mg/dl or acute pulmonary hemorrhage. 50% had active glomerulonephritis. Remission in 71% after a median of 4.2 months. Relapses occurred in 36% after a median of 29 months. Toxicity, PCP in 4 with 2 deaths. WG, efforts to find less toxic alternatives to cyclophosphamide. UVA's trial of EMCs versus Psych, de Groot, et al. Arthritis Room, 52-2461-9, 2005, in ANCA-associated vasculitis. 94% at WG. Patients with life-threatening disease excluded. Serum creatinine above 2.5 mg/dl or acute pulmonary hemorrhage. 30% had active glomerulonephritis. At 6 months, the remission rate with EMCs, 89.8%, was not inferior to Psych, 93.5%. Relapse rates at 18 months were 69.5% in the EMCs group and 46.5% in the Psych group. Summary of methotrexate as an alternative to cyclophosphamide for induction. EMCs, given at a dosage of 20 to 25 mg per week in combination with glucocorticoids, has emerged as the standard remission induction regimen for WG in patients whose disease is classified as limited, early systemic, or non-life or organ-threatening. However, relapse remains a problem. WG, maintaining remission. Options. Continue cyclophosphamide for 12 months after remission is achieved. Switch to methotrexate or azathioprine as soon as remission is achieved, usually 3 to 6 months. Methotrexate to maintain remission. De Groot, et al. Arthritis Room 1996, 39-2052. Langford, et al. Arthritis Room 1999, 42-2666. Azathioprine to maintain remission. Jane et al. Enengel JMed 2003, 349-36. WG, new agent etanercept rituximab. J trial, Enengel JMed 2005 352-351-61. Failed to show that etanercept was effective in maintaining remission, no difference when compared with control groups. 6 solid tumors versus none in controls. Rituximab. 11 refractory patients all responded with remission and decrease in ANCA titers, 8-11 became ANCA negative. Arthritis Room. 2005 Jan, 52-1, 262-8. Microscopic polyangiitis, MPA. MPA was first recognized as a distinct entity by Davson and colleagues in 1948. Described as a subgroup of polyarteritis nodosa, distinguished by the presence of segmental necrotizing glomerulonephritis. The Chapel Hill International Consensus criteria defined MPA as a necrotizing vasculitis, with few or no deposits, affecting small vessels, i.e., capillaries, venules, or arterioles. It was noted that MPA is frequently associated with necrotizing glomerulonephritis and pulmonary capillaritis. MPA, clinical features. Percentage. Constitutional symptoms. 76 to 79. Fever. 50 to 72. Renal disease. 100. Arthralgia. 28 to 65. Purpura. 40 to 44. Pulmonary disease. 50. Neurologic disease. 28. ENT. 32. MPA, renal disease 100% occurrence reflects ascertainment bias. The renal lesion of MPA is that of necrotizing glomerulonephritis. It is indistinguishable from the renal lesion of WG. MPA, pulmonary disease. Lung involvement is common in MPA and is present in more than half of reported cases in most series. Diffuse alveolar hemorrhage, DAH, is the most serious form of lung involvement and has been reported in 12 to 29% of patients in several series. The clinical manifestations range from mild dyspnea and anemia without any hemoptysis to massive hemorrhage and bleeding with profound hypoxia with acute onset in most patients. The radiographic features of DA are nonspecific, demonstrating patchy or diffuse alveolar infiltration. The characteristic histopathology of MPA is that of pulmonary capillaritis. MPA, diagnosis problems in diagnosis variable clinical presentation. Histologic findings not specific. Imperfect association with ANCA, anti-MPO. ANCA, anti-PR3, can be positive in MPA. Differentiation from WG may at times be difficult. Granulomas are not always found in WG. Prominent involvement of the upper respiratory tract or the presence of PR3 ANCA should seriously raise the possibility of WG. Churg-Strauss syndrome, CSS. The syndrome defined by Churg and Strauss in 1951 has undergone several redefinitions but is still characterized by three histopathologic features: necrotizing vasculitis, infiltration by eosinophils, extravascular granulomas. The 1994 Chapel Hill classification defined the disease as a neosinophil-rich and granulomatous inflammation involving the respiratory tract, necrotizing vasculitis involving the medium-sized vessels, associated with asthma and eosinophilia. Churg-Strauss syndrome, bowel, photomicrograph. The biopsy of the bowel wall in a patient with Churg-Strauss syndrome shows a blood vessel with subendothelial fibrin accumulation and non-necrotizing transmural inflammation with lymphocytes and polymorphonuclear leukocytes. Eosinophils and scattered multinucleated giant cells are also present. Hematoxylin eosin, medium power. Number 9412091. CSS, clinical features. CSS is characterized by three distinct phases. Prodrome, dominated by allergic features, is common in patients ultimately diagnosed with CSS. Allergic rhinitis and asthma may often precede diagnosis of vasculitis by 3 to 7 years. Systemic vasculitis. CSS, organ involvement. Pulmonary disease. Pulmonary infiltrates. Pleural effusions, often eosinophilic. Pulmonary hemorrhage. Nervous system involvement. Peripheral neurologic involvement often dominates the clinical picture and has been reported in the majority of patients. Renal disease. Kidney involvement is less common in CSS than MPA or WG. Skin involvement has often led to confusion, for the term Churg-Strauss granuloma may be seen in other disorders. Palpable purpura has been observed in nearly 50% of CSS patients. Diagnostic approach to small vessel vasculitis. vasculitis suspected, lung renal syndrome, purpura, neuropathy. ANCA associated, not ANCA associated. Granulomatous. IgA deposit. Yes. No. Yes. No. Asthma/eosinophilia. MPA. HSP. Cryoglobulins. Yes. No. Yes. No. CSS. WG. Cryoglobulinemia. Other.